Hello, and thank you for joining us for this presentation, Manage Diabetes Risk and Cost in Your Health Plan. This program is part of the SHRM webcast series. You can learn about upcoming and on-demand events from our e-newsletters and the webcast homepage at shrm.org/webcast. SHRM thanks the Diabetes Leadership Council and Breakthrough T1D for sponsoring this program and our series of free webcasts for the HR community. I'm now pleased to turn over the webcast microphone to our first speaker, George Huntley, CEO of the Diabetes Leadership Council.
Hey, thank you, Connor, and my good friend Aaron. Aaron, why don't you please introduce yourself, and then I'll go back to me.
Yes, thank you, George. Aaron Turner Pfeiffer, I'm the Director of Health Policy at now Breakthrough T1D. And for those who aren't familiar with Breakthrough T1D, there's a good reason for that. Until a week ago today, we were JDRF. And so new name, same organization, same mission. The reason for the change is a couple of reasons. Primarily, the name JDRF historically stood for Juvenile Diabetes Research Foundation. And as we know, things change over time, science evolves, and juvenile diabetes is no longer an appropriate term. We know folks today diagnosed as kids are living well into their later years with type 1 diabetes. So a lot of kids diagnosed, now adults. And we now know that nearly half of all people diagnosed with type 1 diabetes are actually adults. And so the name was misleading, and we've known for a long time that this name wasn't representative of our larger community. And so had the opportunity to change names. Breakthrough T1D, I think, underscores and highlights our focus on not just curing type 1 diabetes, but improving the lives of those living with type 1 diabetes in the meantime. So that remains our focus. Again, same organization, just new name. So you'll be seeing this more and more, but Breakthrough T1D, formerly JDRF. So that's us, George.
Hey, thanks, Aaron. And it is our pleasure to continue to partner with Breakthrough T1D under your new name, and it's been a great relationship. Again, to the group, I'm George Huntley. Thank you so much for joining us. I'm a patient actually living with type 1 diabetes for 40 years. I'm the CEO of the Diabetes Leadership Council. In my other day job, which I finally am getting out of, and now I'm focusing on DLC, I have been I'm the CFO of a professional services firm based out of Indianapolis, Indiana, for about 20 plus years. I have been the plan administrator of an employer-based health plan for over 25 years. So I have the payor perspective that this audience has, in addition to the patient advocate perspective. DLC is a policy advocacy organization trying to educate policymakers and through this employers on things that we can do to make the lives of people with diabetes better. So I appreciate the opportunity to be here today, and thank you for your time. We're going to cover the state of diabetes care and coverage. We're going to talk about you're going to hear from some medical professionals talking about what it takes to live with diabetes. We're going to talk about marketplace dynamics influencing diabetes care and costs, and we're going to hear from a HR executive, really a third-party administrator, about plan designs on this and drug costs. So appreciate all this. Please put your questions in the Q&A. We will get to as many as we can. It's going to be a fast show. So with that, Aaron, I'll leave it to you.
And shout out, George is in Ohio today. If you're wondering, if you're a Cincinnati Bengals fan, over my shoulder here is one of our youth mentors. Right tackle for the Cincinnati Bengals, Orlando Brown Jr. So if you're wondering what's behind me, yes, that is Orlando Brown Jr. And yes, I am a Cincinnati Bengals fan. Hooday. So jumping into the presentation, I'm going to quickly cover just some general information around diabetes. We have a great panel here to dive into more details. Again, as George said, any questions we can come back to, please put in the comment box here. But as many or all of you might be aware, diabetes is an epidemic. 1 in 8 adults living today in America have diabetes. Roughly 38 million Americans, 98 million Americans with pre-diabetes, pre-type 2 diabetes. If you're wondering, 2 common types, type 1 and type 2. Type 1 typically characterized as an autoimmune condition where folks can't produce insulin. Type 2 can be metabolic or autoimmune, and folks are either insulin deficient or resistant. The vast majority of folks living in America today do have type 2 diabetes. You can see the split here, 95% to 5%. And so diabetes is chronic and progressive. There are no quote unquote cures today. We're seeing tremendous progress in cell therapies, particularly on the type 1 side. But it's chronic and progressive. And what we mean by that is the longer you have it, the greater the likelihood of complications, costly complications. So roughly 1 in 3 folks living with diabetes age 40 years or older or living with diabetic retinopathy. Folks with diabetes are 2 to 4 times more likely to die of heart disease. Roughly half, nearly half of all new cases of kidney failure are happening in folks with who have diabetes, and 60% of non-traumatic amputations are occurring with folks with diabetes. So these are not only costly complications; these are life-changing, potentially fatal complications for folks with diabetes. And as you might guess or already know, living with diabetes and these complications is a significant driver of costs. 1 in 4 health dollars spent in 2022, 413 billion, big number here, an annual cost of diabetes. It's not just direct medical spending, which we can all guess, but it's also this reduced productivity. As we'll talk about and hear more about in our panel, living with diabetes is hard, and the more we can do to ease that burden for folks living with diabetes, the better we can do to make that lead better and more productive lives. And so here's a thing we want to underscore. Insurers are reporting spending 3 times as much on a person with diabetes with complications than someone with diabetes and no complications. And so, there are limited things right now, therapy-wise, that we can do to cure or prevent diabetes, but there's a lot we can do to better manage diabetes. And we're spending a lot of money now on complications and not as much as we should be spending on management. Now, as we're talking about this, we want to make sure we underscore the importance of health equity. Love the visualization that this does between equality and equity. When we talk about equality, especially on insurance, we're talking about everyone equal coverage in our policies. And what that looks like, though, is not everyone's starting from the same place. And you can see here on the far left, the shorter person still can't see the baseball game being played here. And when we talk about equity, it's ensuring that one coverage policy, but folks are getting what they need, and those policies are meeting them where they're at, so everyone can see the baseball game. And here, if you look past the fact that we have too many folks on the field and a rule violation, one day we want to get to a place where there are no fences here and everyone has equal access. So what do we mean when we say equity? What we're talking about is equal or equitable access to diabetes technology. We are aiming for the highest level of care, but often we're talking about just ensuring folks have the basic standard of care. We'll talk about that more with our panel, but we're talking about access to diabetes technology, medication, and supplies, the appropriate healthcare providers and centers of excellence, and ensuring that their communities that they're living in have access to healthy foods. And so we'll see here the impact of disparities, but we have good data showing disparate outcomes in folks with diabetes. What this looks like is that disproportionately impacted communities aren't getting access to key diabetes preventative services, things that help reduce complications, and access to services that improve health literacy and health insurance literacy. And we're going to talk here in a second about demographics breakdown by race, but health disparities occur not just based off of race, but we know there are other co-associated factors that go in, including things as simple as zip code and economic well-being. So here we do want to highlight disparities by race. You can see moving left to right in the chart, non-Hispanic Black compared to non-Hispanic white counterparts are diagnosed at over 50% more often. And if you look, the two ends of the spectrum here, comparing non-Hispanic white to their Native American and Alaskan Native counterparts, diagnosed roughly twice as much for Native American and Alaskan Natives. And so disproportionately impacting communities of color. And what this means in real terms, we again have good data showing what this looks like and the impact. Folks of color with diabetes are less likely to be prescribed CGM or insulin pumped. Often that's the standard of care. They're less likely to receive education regarding newer technologies, less likely to have access to newer technologies, less likely to have access to appropriate education and support. And we know that access to these education and support improve outcomes, and they're less likely to be prescribed newer types of insulin and glucagon. And so they're less likely to get the good things, more likely to develop the bad things, more likely to develop the complications we just talked about regarding nerve damage and eye and kidney damage, and they're more likely to be hospitalized for severe high or severe low blood sugar levels. So we highlight this because it's an important area to highlight for not just your employees, but as a larger community. Where there is good care occurring, these aren't equally distributed across our communities. Again, underscoring here, 2.6 times more expensive to care for a person with diabetes than with that one. 38 million Americans are accounting for 19 million ER visits, roughly 48 million inpatient hospital days per year. So roughly each person staying more than once in an inpatient hospital stay. As you all know, some of the more expensive care that you're going to provide under your plan. And there's a lot of room for improvement here. Again, better management, more focus on better management, less focus on dealing with these complications goes a long way. And I do want to highlight here one key stat: 89% of folks type 2 diabetes are overweight or obese. I know there's already been one question come in the chat. We're going to spend some time with our panelists jumping in here. And one of the places where, at Breakthrough, I have learned a lot in this space. I have a lot of friends now with type 1. I don't have type 1 myself, but this diabetes, type 1 and type 2, is a self-managed condition. So for the Rent fans out there, 525,600 minutes in a year. Less than 120 minutes a year is going to be spent with your healthcare provider discussing and solving your diabetes. And so this is a lot of work on the person with diabetes to manage themselves. People with type 1 are making an extra 180 decisions a day compared to someone living without diabetes. So this is a lot of work for the person with diabetes, and better benefit design goes a long way in making and reducing this burden and making your diabetes easier to manage. So with all that being said, I'm going to pull in here on camera Dr. Schatz from the University of Florida and Carmine Kulkarni, our resident expert diabetes educator. She jumps on camera. Welcome, both of you. Thank you for being here. We covered a lot of ground there.
Thank you.
I've got some questions I'm going to jump us right into, but feel free to circle back on anything that I've already touched on. Dr. Schatz, first question. I think I want to start with kind of just a baseline understanding of what's happening in the body when someone's diagnosed with diabetes. What are some of the key differences between type 1 and type 2 diabetes?
Well, thank you very much. And I know everybody really wants to know more about cost, but I think it's really important that you understand exactly what happens in diabetes. There are really several types of diabetes. The two major types are type 1 and type 2, and they relate to the body's production of insulin by a organ called the pancreas. The beta cells of the pancreas, the endocrine pancreas, makes insulin. In type 1 diabetes, there is an absolute deficiency of insulin because of a so-called suicide on the body. Your own body's white cells attack and kill your own body's pancreas. In type 2 diabetes, which was previously thought to affect really mostly and only adults, which now affects many children as well, there is not only a relative deficiency of insulin, mostly because of a more sedentary lifestyle, because of overweight and obesity, a lack of exercise, genetic predisposition, but over time there is a lack of insulin as well. What that does is that without insulin, there's an inability of the body to use sugar as a source of energy. Now, everybody with type 1 diabetes has an absolute requirement for insulin. And now 1 in 3 adults with diabetes require insulin daily. And you're going to be seeing more. I think there's certainly a question in the chat about the use of adjunctive therapies, which cost a lot. These are the SGLT2s and then the GLP-1s. But the bottom line is that many people require insulin, and so many of the patients, their cost is not covered by the insurance, and then it gets a significant out-of-pocket expense. Next slide, please. Now, one of the questions has always been is it your fault? Is it your fault that, you know, you're overweight, you're obese? Well, I think that we need to really shift the paradigm, really from blame, certainly to biology. And, you know, we sort of think about, well, you know, what is going to be overweight? Well, you look at a body mass index, and really, certainly in almost all populations, perhaps Asian Americans, where it's a little bit lower, but when your body mass index goes above 25, we're saying you're overweight, and then certainly above 30, you're obese, and there are various stages of obesity. And why is it important? It's important because it has a significant risk, not only for diabetes, it has a significant risk for other conditions, which include hypertension and hyperlipidemia, that's high fats. And it's really important that we pay attention, certainly, to this. We do know, as has already been said, there are social determinants of health. There's increased risk in African Americans, in Hispanic and Native American Indians, in those of Asian descent. But the bottom line is this leads to complications, and particularly in younger people, you get complications within 10 years. So there's an urgent need to do something, and to do something as soon as possible. And I will turn the podium back to you, Aaron.
And I think that's such an important point here, this idea of blame, shifting from blame to biology. And I'm curious if you could just expand a little bit about, I always find this fact that the body defends its highest set point, just how challenging it can be for someone who's doing everything that they can to try and lose weight here. And just, if you could just underscore that a bit, because I think that's an important point.
Carmine?
Yes, thank you. Yeah, no, it's unfortunately socially, all of this time it's been, you see a person who is overweight, there's judgment and there's blame. There's no thought ever given to, there's a biological reason, there's the metabolism is off. Now obesity is finally being classified as a disease. And that's the right thing to do, because it's not a blame thing, it's not a character flaw, and there's treatment, and the person has to be treated just like we treat any other chronic disease. And like Des just said, there are the social determinants of health and the disparities in a lot of the minority populations in the United States that also have a disproportionate share of the diagnosis of type 2. So when you combine the two, it's like a double, triple whammy to the person, to the body, and then also to the healthcare system. But if it's taken care of upfront, recognized, and the person has a team to work with, and the medications and everything else to support that individual, along with lifestyle intervention, that would make a huge difference. I'll pause there. Thanks.
It's such a great transition here. Some of the challenges with obesity and being overweight. And I think the thing that I maybe hear the most here at Breakthrough T1D is how hard it is to manage diabetes. And so can you just speak a little bit about, you know, the multitude of factors that go into managing diabetes on a day-to-day basis?
Yes, absolutely. Thank you for asking the question. I think that is such an important question because it's a huge challenge. It's a daily challenge. It never goes away. It doesn't take a vacation. And there's like On the slide, it says 42 factors affecting blood glucose, but I mean, there's 40 to maybe 100 factors, depending on the individual, because no one's diabetes is the same. Everyone's diabetes is individual, personal to them. And no 2 days are the same in terms of the management, regardless of how meticulous they are and how well they use the technology and all the knowledge and information, because life happens. So if you start off with the whole category of food, under that category, person is juggling quantity of carbohydrates, the grams of carbohydrate, fat, protein, fat and protein, and the combination and their impact on blood glucose. If they have an alcoholic beverage or a few alcoholic beverages, what does that do? Then in terms of the timing of the meals, timing of snacks, adequate fluid intake, just the whole situation in terms of all of that, and that's lots of numbers. That is a lot of numbers in terms of their management, number of grams of carb and protein, fat, and timing of meals, and they're balancing that and matching it to their insulin if they're type 1 or type 2 requiring insulin. So medication dose, that's a whole huge another area too. It's the amount of the medication, when to take it, the medication interactions, because a person with type 1 or type 2 diabetes typically just doesn't have diabetes. They also may have hypertension, dyslipidemia, arthritis, a bunch of other chronic conditions for which they are taking medications. So they're managing those medications, maybe interactions with the diabetes meds and dosing and amount and when to take it and all of that. So that is also very challenging, and also a lot of numbers. If they're on insulin, then they're managing how much insulin, when, in relation to their blood glucose and all of that math. So do they carry around a calculator and keep working with numbers there? Then you've got the component of physical activity. So there's the impact of any kind of activity on blood glucose is well known. So, is it a light exercise day? Is it a heavy exercise day? Is it a weekday versus a weekend? The time of day, the matching up of food, the insulin or the medication, and the activity to avoid hyperglycemia, to avoid hypoglycemia. So it's like a juggling act. It's balancing all of the time, 365 days of the year. Like I said, there's no break from it. And then, of course, you're looking at all of the other biological factors of stress and hypo or hyper. If they're traveling, the time difference. You're looking at then with women with diabetes, you're looking at menstruation, puberty, menopause, all of those conditions at age impact glucose levels. There's a lot, and you can have a person with diabetes being very meticulous about their doing everything that they've been encouraged to do, and the knowledge we provided, technology is there. But sometimes happen, and I see a new slide.
Carmene's audio is breaking up a little bit here. I'm going to pull in Dr. Schatz here our last couple of minutes and ask you a bit of maybe of a loaded question here, particularly around, we know innovation and everything that Carmene was talking about. And thank you, Carmene. I think you're back on now around just living the day-to-day living with diabetes is so challenging. But innovation is allowing for, I think, more personalized care. And I'm curious, Dr. Schatz, if you can just talk about how access to continuous glucose monitors, what that's doing for folks with diabetes, and how that's changing kind of management of diabetes care.
We have really progressed from urine testing to blood glucose testing, and now to continuous glucose monitoring. And if we sort of think about just placing a continuous glucose monitoring on the arm or any other parts of the body, that are recommended, we can get a reading really up to nearly 300 times a day. And this will also tell you not only what the absolute blood sugar is, but where the blood sugar is moving. Think about checking a blood sugar. We sort of do this 5 to 6 to 7 to 8 times a day, but in this case, we can really get it every 5 minutes. And soon to be, with innovation, we'll be getting it even more often. And the reason that it's so good is that it enables the patient to have more control. The patient is in a decision-making modality. They can see the results of their decisions, what they ate for breakfast, what was the impact of emotional stress on exercise, and they can certainly see this in real time. And I really think it's important as we think about it that we're looking at an expectation for patients, their time that is in range, because we know how important it is for their day-to-day activities. We know it's important to prevent short-term complications such as hypoglycemia, diabetic ketoacidosis, and also long-term, complications. So it's really, really important. And, CGM has enabled us to move to automated insulin devices and greater technology, where hopefully that ultimately we will get progress towards an artificial pump. But not only in that direction is there great innovation, but at the biological sense, we're now coming up with new drugs that could potentially delay the onset and hopefully in the future enable us to have an inordinate and innumerable number of cells that are going to enable us to cure the disease. So there's wonderful innovation that's certainly on the horizon, and that we can look forward to improving the lives of patients with diabetes.
I could have this conversation for hours, but I know we've got to move along here and hand things over. I want to thank both of you for joining us today. It's been so informative and such a great kind of baseline understanding of living with diabetes and also how we're caring for folks with diabetes today. And so with that, I want to thank both of you. I'm going to pull in George here back on screen and hand things over to you.
Hey, thanks, Aaron, and thank you, Carmine and Des, for your time today and your expertise. And we're going to move on to marketplace dynamics influencing diabetes care and cost. So let's get into the money side of this, because I know a lot of you care about that. And I'm going to start with the example of insulin. It's the poster child drug for what's going wrong with drug pricing and health plans. You can see here the list price of insulin for the last 10 years, from 2012 to 21, and the same, it's continuing in 22 and 23, has grown 143%. The cost of a vial is around $300 today. The net price of insulin, however, during that same period has been cut more than in half. More than in half. In fact, it's nearly 60% if you go into 2022. It just continues to drop. So that delta is the rebate that the pharmacy benefit manager is charging for access to the formulary. So the pharmaceutical companies are paying that rebate to the pharmacy benefit manager. And I want to point out, you can see in the case of insulin, it can be 70% of the list price of drugs or more. It's 48% on average for all branded drugs. So on average, the branded drug list price is literally half what the net price. The net price is literally half what the list price is. So let's talk about how the system's actually working and how it flows through. And this is the slide that we affectionately call the hairball. And you take the consumer, which is your plan participant, your employees. You're going, and you're paying a sack of money here for your insurance premiums being taken out of your paycheck on a weekly basis, bi-weekly basis, however often and you're paying that premium to get access to the health plan. I liken it to like you're paying Sam's Club dues and you're getting access to Sam's Club. And if you're going to the hospital or the doctor, you are actually getting Sam's Club pricing. You're getting an explanation of benefits that says what the hospital charge, what was the plan discount, what's the net, and if you're in their deductible, the patient owes some of it. But you see all of that, and the patient is always getting the benefit of that negotiated price. But in the drug side of the plan, you've paid access to Sam's Club, but you're paying Tiffany's prices. So a patient in January, the ball drops, we celebrate the new year, and now you need insulin. Well, if I need 3 vials of insulin, and by the way, some people need 5, depending upon the level of insulin resistance they may have. If I need 3 vials of insulin, that may list at $900. That $900 is going to come down through the pharmacy, basically to the drug company. The manufacturer is effectively getting that $900, but they are then passing 750 of those dollars. And these are relative figures, but they're relatively correct. So $750 of the 900 is being passed to the left on the screen to the pharmacy benefit manager. The pharmacy benefit manager is getting that money to providing access to the formulary so that the privilege of charging you $900. The 750, the PBM is keeping a piece of it. It's not really well disclosed. We know from the state of Texas, who has transparency laws in place, that the PBMs are keeping on average over 10%. But your contract may vary, and they may tell you you're getting all of them. Okay, fine. But it's now going up to the health plan. Well, the health plan is your company if you're a self-insured ERISA-based plan, or it's the insurance company if you're in a fully insured environment. But what's happening here is that the sick are subsidizing the healthy, because the health plan, the insurer, is keeping that money, and it's offsetting the overall cost of the plan, so that the premium that everybody's paying, that sack of money that's going out of your paycheck, the premium is being kept low. But again, the sick are subsidizing the healthy. That's not how it's supposed to work. So we've got a scenario where it's reverse insurance and not the way it should ordinarily flow. Now, relationships are blurring this because they're all vertically integrated. So let me look at the PBMs, and you say in that second row, Optum Rx, CVS Caremark, and Express Scripts. Those 3 players have 80% of the U.S. drug market. That's a commanding chunk of the U.S. drug market. But they are owned by the insurance companies. So United Healthcare, Aetna, Cigna, all within the corporate family, and they own specialty pharmacies and some provider services. So they're sending you to their own pharmacies, and you look at to say, how is this all manifesting out there? United Healthcare, as an example, made $24 billion in profit in 2021. Over half of that profit came from Optum Rx. Over half of it. Now, drugs are 10 to 15% of a health plan. You know this because most of your health plan costs are actually hospitalizations. But Optum Rx drove over half of the profitability for United Healthcare. So we look at it, we say, we want the patients to have access to their medications, because the underlying theme of this is a patient with diabetes costs you less if they actually take their medications. I'm going to go to the bottom of that. June 2022 study, Express Scripts capping the cost of diabetes meds at $25. That's not just insulin, that's all diabetes meds. If you did that, you would reduce your overall diabetes costs 16.3%. If you've had nothing else out of this webinar today, you can cut your cost of diabetes 16.3% if you cap the cost of all diabetes-related meds. I encourage you to strongly consider that. Look at your health plan. You're either charging $25, potentially $360 if you're passing rebates through, or if you're not, and this instance is 4 vials of insulin, you're looking at $1,200 a month. How many people have that kind of money in January freely ready to spend? And if you have a chronic disease, you are making very difficult life choices about rent, car payments, groceries, what am I doing? And what they are doing is they're rationing their insulin. 69% of patients will abandon prescriptions if it costs more than $250. A type 1 is not going to abandon their insulin, but they are going to ration it. A type 2 may abandon it altogether. That is really bad for your health plan, and it's bad for the health of your employees. So what we're talking about is please pass through those rebates at point of sale. And one of the big questions that we get is, what's it going to cost me? And the answer is nothing. It's negligible. We have an actuarial study that says it's 0.4 to 0.6% of an overall health plan. One thing to bear in mind is you're not buying drug insurance. You are buying health insurance. You are running a health plan, not a drug plan. Drugs are 10 to 15% of a health plan. So you want people to take their medications so that the rest of the big bulk of that spend is actually lower. A patient with a chronic disease is going to meet their deductible pretty much 100% of the time. If you think about the ones that are really driving your spend, you're talking about passing through rebates during that finite deductible period. People who never meet their deductible, their impact on, or if you pass the rebates through to them, it's going to have an impact on your plan, but it's not a big deal. They're not even meeting their deductible, so they're not your big plan spenders. But the big plan spenders, the chronic disease patients, et cetera, we meet our deductible 100% of the time. If you overcharge them for their medications, congratulations, you are going to pay another claim that you would not otherwise have paid. It is a complete false set of economics, but what you've done is you've trained them to ration their drugs and be less adherent to therapy. So you've taken a high-risk patient on your plan and you've increased their risk versus lowering their risk. And again, if you look at the brand, you look at the rebates are on branded drugs. If a health plan is 10% drugs, and even if it's 15, you can follow math, but this math is easy. If it's 10% drugs, 20% of a drug plan is generics, no rebate. Only 30% are branded. The other 50 is specialty. There might be a rebate on the specialty, but the specialty drugs are so expensive, you meet the deductible so quick you don't even see it. And again, you get back to the false economics. Branded drugs at 30%, you're talking about a 50% rebate. You're down to 1.5% of the plan, and then you say you're only doing it during that deductible period. It's very easy to get to well below 1% impact on the overall plan, and that has no impact whatsoever, no accommodation whatsoever for actually having healthier patients. Because back to that Express Scripts story, we know that if a patient actually takes their meds, they cost less. So I'd like to move us very quickly to a poll question. So hopefully we can get this. Does your organization offer at least one plan with rebate passed through to my plan members? You may not know. This is yes, no, I'm not sure, and not sure is fine. But some people are passing through rebates at point of sale. My company that I just sold, we've passed through rebates for over a decade. And I encourage you to take a look at this, and I'm gonna watch the numbers come up here, and I appreciate your participating in this. I'm gonna give it just a second more. It's like the microwave popcorn when the kernels just stop popping a little bit. All right, let's see where we are. All right, 9% are passing it through, 48% no, and 42% not sure. And I would hopefully encourage you, and I thank you for your participation in this. I would encourage you to consider it. It is going to cost you virtually nothing. It has not driven up my plan. It is not. We've got this law passed in Indiana, Arkansas, West Virginia, and now New Mexico. It has not driven up plan premiums in West Virginia and Arkansas in particular. So I want to just drive that home. You can cut the cost for your people, and it costs you nothing. Generics and biosimilars. What we have is a perverse incentive that the pharmacy benefit manager has, because their revenue, what they make off of this is based upon the price of the drug, and specifically the list price of the drug. So they are not putting generics on the plans. When a generic comes out, you say, hallelujah, welcome to the party, bring them on, because I want to get a lower cost drug for my people. And unfortunately, this is Medicare Part D data, but it's the same PBMs, folks. They're behaving the same way. I can just get this data. Only 25% of generics are covered in the first year. Less than half of them are on the generic tier. Why wouldn't you encourage them to go down to that tier? You've got no incentive to take the generic over the brand drug. It's costing you money. 93% to 45% on the generic tier. And this is not just diabetes drugs. What's going on out there in this? Take a look at what you're exposing yourself to. Speaking of exposing yourself to, this is an area of risk that we're just now beginning to talk about. Health plan administrators have a fiduciary responsibility under the ERISA Act. Johnson & Johnson is being sued by its employees, not as a provider of medical products, but as from their employees in a class action suit on a breach of fiduciary duty to manage drug costs. You are taking your employees' premiums. This is very similar to a 401k plan where you were taking your employees' money and you must invest it wisely. You must manage the plan administrator and the fund balance, the funds of all of things that they can invest in. This is the same principle, but it's now coming on health plans, not covering lower cost generics. You're not even offering the low cost generic. It's not even on the plan. So they have to, especially during that deductible period, pay hundreds of dollars more for the branded drug. That's a problem. And it's the plan administrator's responsibility to make sure that you're protecting your participants. Failing to manage that provider costs, lack of transparency. CVS Caremark is being sued on a whistleblower suit for preventing access to generics and lower cost drugs on Medicare plans. I encourage you to look at this. This is an area that is late breaking. This lawsuit dropped in February of this year. Des talked about this, Dr. Schatz talked about this briefly. Obesity coverage is diabetes prevention. And there are now effective obesity medications out there. And I encourage you to consider these. They are driving, there's a lot of demand for it. It is going to be an employee retention issue. We actually have a full program that we held on. If you're on SHRM here, go to their website on May the 30th. You can watch a full hour episode on obesity medications. And I encourage you to take a look at that. High deductible health plans increase diabetes complication and risk. This is a report that came out of JAMA, the Journal of American Medical Association. This is one of the top publications in the medical world out there that did a study. When you move a patient to a high deductible health plan, look at what happens to the increase in hospitalization, the end-stage renal disease, lower amputations, basically. This is what happens when a patient no longer adheres to medication. It is so important because all of that can be avoided or delayed in a serious way. But that's what's happening when you go into these high deductible plans. Be very careful. I'm going to actually skip this. So I'm going to go right over here because we're running low. And I'm going to invite my friend, Rich Musti, to join us here to talk a little bit about the health plan design. And Rich, thank you for being here. And let me just a quick bio on Rich. Rich Musti is a co-founder of United Group Services, located in Anderson, Indiana. In full disclosure, the company I worked for, we worked together for a decade or more. Rich is a licensed insurance agent and member of the Society of Professional Benefit Administrators, the National Association of Health Underwriters, and the Self-Insurance Institute of America. Unified Group Services is a full-service third-party administrator, TPA, for self-funded group health plans, dedicated to providing employers with innovative programs, services, and tools to effectively control employee costs. So, Rich, thank you so much for being here. Can you just give us a little bit more background on the, how many clients, the size of UGS, and the type of clients that you're dealing with, and then we're going to get into rebates, if I may.
Okay. Yeah, I'll go quick. Thank you for the introduction.
Yeah.
a neighborhood of about 80,000 lives that we administer. And our average customer is probably in the neighborhood of a couple hundred employees. We have everything from a couple thousand down to 50s. That runs across a couple hundred employer groups. That's in the self-funded arena, as George mentioned, a full-fledged third-party administration business on a fully, really customized basis per plan.
So that's so you've got soup to nuts, small to medium to 1,000
Yes.
employees. So hopefully the people in the audience are seeing themselves in that list, if you will. I mean, there might be some General Motors watching, but this is business in America, if you will. So I know that you've been passing rebates through forever. You've been certainly talking to us about doing so, and we've been doing it at Beerus. Are you doing it for your own employees?
Absolutely. Our own plan is self-insured, 170 some employees, and we've been passing through rebates at point of sale. Obviously, when they're at the pharmacy, in the neighborhood of 15 to 16 years.
And from your cost perspective, and then I'm going to move to your clients, has that impacted your bottom line? You've seen
no question, George. We've been able to maintain a competitive health plan and keep the RX manageable. We have about 90% of our purchases on our employee plan is generic, so it doesn't leave a lot of room. But when we get that, or that other 8 or 9%, that's name brand, the employee, the participant, as you've been mentioning, is absolutely benefiting at point of sale, whether it's a $100 rebate or sometimes it's in the $1,000 rebate, that they receive that at point of sale when they walk out of the pharmacy with their prescription. The other 1 or 2%, unfortunately, are making up 40 to 50% of the cost because of specialty. But those also have rebates. Those are passed through as well.
And so you're obviously, you as a client, you've been giving us that counsel, which we have followed for a very long time. How many of your clients are actually passing rebates through? Can you share just a percentage roughly?
Percentage, George, is north of 80%. And in some situations, and this is not taking a shot at brokers or consultants, but sometimes we acquire business where the broker or consultant might already have in place a PBM, and they say, don't touch it, let's leave it with who it is. And we don't have a chance to bring in our offering and our solution. And but more, as I spoke, more than 80% of the time, we're typically bringing the PBM in place and deploying rebates at point of sale from day one on.
And let's talk about what that means when you're dealing with the PBMs themselves. So when you're negotiating with the PBM, you're deciding which one to. They'll all pass these through, right? What's that? What is that? What do you have to do to make that change?
It's a matter of renegotiating the contractual arrangement, and maybe there's a few that we've run across that do not. That's why we work with a really finite number, a low number of PBMs for purposes of going way beyond PBM management. Including proper formularies, managing specialty medication, getting help financially from the foundations. So we get very aggressive on the RX side, but keeping the patient in the forefront and keeping them from being delayed of getting their prescriptions. And it's a very customized thing. I'm biased to self-funding, but it's tailored to these groups. And I've had my own TPA for almost 30 years now, and I still have my very first customer from that time. So we take a great pride in adapting to the industry and rolling with it while delivering, hopefully aggressive but financially sound programs.
So I'm going to morph us a little bit as we think about the generics and the coverage of those. I think Aaron, in passing mentioned, I'm actually in Columbus, Ohio today, giving your presentations, these educational presentations to members of the Democratic and Republican caucuses within the insurance committees there, talking about these issues. One of the things that has come up today was, the cost of Humira. It's not a diabetes drug, but this is, again, a health plan. Humira, the monthly cost of Humira is over $8,000. And there is a generic for Humira that's about $184, if I remember from the part of this presentation. And some of the PBMs aren't covering literally the drug that's $8,000 a month cheaper. I'm sure you're not experiencing this, but you see it in the industry.
Right. Yeah, George, again, back to the really tailored approach with the customer's input, not just dropping a PBM as part of a package, but they play significantly in the design of the plan, and that formulary and the first pass has to be looking at the generic if it's capable of therapeutically doing the same thing. And I mean, like you're speaking, I mean, we all know there's significant savings. I'll say this across my book of business, if we look at ourselves introspectively every year and on an ongoing basis, our clients' collective net trend was -3% on RX last year. And I can back that up with tremendous evaluation of across the board of our healthcare plans. And that's from taking this customized approach, rebates at point of sale, looking for foundation help, and absolutely available. So
that's amazing. That's an amazing result. The other thing that I heard we discussed today is gets on spread pricing. Where the PBM is buying the drug from the pharmacy for $5 and charging the plan for $25. And I'm making those up, but that's not far. There are many scenarios that happen that
right.
The management of that, is that something that you can build into a contract? How do you address that?
It's absolutely built in, Georgia. Our contracts are 100% auditable, and there is no spread pricing whatsoever. The PBM is paid an access fee for using their services as well as their network of pharmacies, and again, you pay a per script fee. And walk away from it. There's no markup whatsoever, and that's an auditable contract.
And that is likely not a common contract for the audience today. That is, and so that's why I'm trying. We're here having this conversation. The PBM.
Right. Can I speak? Let me interrupt you for a second, George. Let's speak real quickly how the money flows on the rebate piece. The way our clients operate and the way self-funding works is we have to pay the PBM every 2 weeks. So with that being said, if it's a $1,000 drug and there's a $500 rebate and there's no rebate deployed at point of sale, then I bill my customer every 2 weeks and they got to pay the $1,000 after the employee, let's say they paid $50, the employer has to wait 9+ months to get that back. And the question is, how much do they get back of that rebate? So they're paying that bill to me. I have to bill it every 2 weeks, and they're overpaying that versus if the rebate's at point of sale, it's $500 and the employee pays a $50 copay, I'm going to bill the customer $450 every 2 weeks, not $950.
And thank you for bringing that up, because that is a really key cash flow implication of this whole rebate program. And again, your
it's significant, George. It's significant. I have customers that rebates average over $100 per employee per month. So if you've got a 100 life group, that's $10,000 a month times 12 months, and a 100 life healthcare plan, $120,000 a year rebates, that's not being paid, and somebody getting part, all, or whatever's happening to that rebate.
And I also want the audience to actually, I'm going to tease one thing you said or underscore it. That was a plan of 100 employees. That's not a huge health plan, okay? That's not a huge health plan. Again, back to the audience to say, can this be me? if you've got 100 people and you're doing it here, you can do it anywhere. If you've got 200 people, 500 people, you can be doing this if you are basically managing the PBM like a vendor. That's what they are. They're a vendor. But making sure that all of your relationships with that PBM are delinked from price. You're paying them for a service to process a transaction, but you've got to delink their compensation from the value of the drug, because if you don't, that's when the perverse incentives happen. You get the wrong things on the line. Rick, I really appreciate you being with us today, and I thank you so much for sharing this in your time. And I'm gonna move on to a wrap, because we're getting really close to the bottom of the hour here, or top of the hour, I guess.
Well, thank you for having me. Just real quick, if there's anybody that has any follow-up, George, you know how to, obviously, we're tightly connected.
We'll get in touch.
Karen, anybody, if there's any additional follow-up, feel free to reach out to me.
We'll do it. Much appreciated, my friend. Thank you, sir.
Thank you. Talk soon. Bye.
Thank you. So in quick summary here, we also have some other options that are on our website to reduce your risk and cost here. You can go to or you hit the QR code here. I think the QR code is going to show up in a minute again. Copay assistance, make sure those are actually going to your employees during their deductible period. It is actually federal law that they do, federal regulation. The opportunity to do a copay accumulator programs are no longer legal. We've talked about spread pricing now, generics. I would encourage you to look at literacy, make sure you're covering diabetes care and education, and telehealth. Look at how your plan is treating telehealth. It saves time for your employees. It saves money because they're not, well, your productivity goes up because they're not leaving the office, and you're taking a half a day off for their plans, but they get to get the help that they need, especially when you talk about those 525,600 minutes. Each one with a healthcare provider is precious. So real quick, after viewing this webcast, are you more likely to consider passing your rebates? And I threw it to plan participants at point of sales. Have we piqued your curiosity, your appetite for this? I would appreciate it if you would just let us know, yes, no, already doing it. We know that a lot of people weren't sure, so I'm trying to get to some of those that see what you think on that. I would appreciate it if you play along. And I hope you've learned something from this session, and had a few nuggets to take away. Diabetes is a very complex disease, and it is difficult to manage this disease. And it is, yes, as Carmine was sharing, you have 42 factors. No 2 days, really no 2 afternoons are the same with this disease. So I'm gonna give it one more second. And so yes, 81% are going to look at it. 19% are not going to look at it. I do appreciate that. It gives us some feedback as we go, and I thank you for playing along at home, if you will. I've been trying to get to some of the Q&A. If you do have a question, please send us a note through our diabetes leadership leadership.org website. And I'm sure you can, reach out to us through SHRM. But I really want to just thank the presenters for their time and sharing their expertise today. But I want to thank you for watching this, and I do hope you found it informative, and have a fantastic afternoon.
All right, thank you so much. This webcast is sponsored by the Diabetes Leadership Council and Breakthrough T1D, formerly JDRF. The Diabetes Leadership Council is a patient advocacy organization whose members are individuals with decades of diabetes experience and leadership who work to advance patients' first policies related to diabetes at the local, state, and national levels by engaging policymakers and public and private sector influencers. This webcast is part of the DLC's efforts to educate employers on health plan design options that lower their plan risk and costs while improving employee health. For more information, please visit diabetesleadership.org. Before we sign off, we want to thank our presenters, George Huntley with the Diabetes Leadership Council, Aaron Turner Pfeiffer with Breakthrough T1D, Dr. Desmond Schatz with the University of Florida, Richard Musti with United Group Services, and Carmine Kulkarni for the information they provided today. And we also want to thank everyone tuning in for being with us and for choosing SHRM for HR webcasts. That concludes this program.